And today we have kicking us off Dr. Hlombe Makuluma, who is the Medical Legal Risk Advisor at Ethical. He provides medical legal advice on various issues affecting doctors, from general advice through to claims, complaints, and notifications. He is really the interface between the doctor and the legal and risk management processes. He's a qualified general medical practitioner with a master's in medical law and ethics. He has a wealth of experience, more than 25 years in the health industry, from operating his own practice, private practice, and working with various corporates and health consulting. He's also the author of a book, The Business of Healthcare Managing Your Private Practice. So Dr. Makuluma today will share his experiences on common medical legal issues affecting neurosurgeons. So I'll hand over to Dr. Makuluma. Thank you.
Thank you very much, Ryan, and good afternoon, everybody. It's always very difficult to prepare a presentation such as this one. I hope my presentation can be seen. Is my screen being shared? Trying to check that first.
Still coming through, Dr. Makuluma.
Still coming.
Yeah. Maybe stop sharing and then, oh, there we go. Beautiful, beautiful.
As I was saying, that it's just almost very challenging to prepare a presentation like this one, because I mean you're presenting a balance between the Fight Club, basically, which is the doctors and the lawyers, trying to find the fine balance between the two. But without wasting a lot of our time, just want to jump into it. If we think about the common issues, I think all the health practitioners have not really been trained around medical or legal issues. Whereas we know that as soon as you start working, you are actually involving yourself into a legal matter. As soon as you interact with the patient, you are interacting in a legal manner. So there are various things that we need to look at. Errors, for example, it's an unintended damage caused by action or inaction of the doctor. Different from a complication. I mean, doctors, they know complications all the time. And within errors, there are three kinds. Negligence, that is not doing what should be done. An assumption there is made that everybody knows what should be done. So if you don't do what should be done, you are more likely to be looked at as negligent. Recklessness, it's doing what should not be done. The most important thing that we see, and we put it as recklessness, that is to operate on a patient without informed consent in a non-emergency situation. With recklessness, we'd always think about, there are doctors who would say, we know so-and-so, he or she is a cowboy. We expected that something like this would have happened. So that is one other way of looking at recklessness. Incompetence, it's doing poorly what should be done well. This one is also very interesting because every generation of doctors will tell you that they don't train them like we used to. So you'd always find that in terms of incompetence, these youngsters, they're unlike us. But remembering that there's always older people, there's always youngsters. If we look at assessing medical negligence, from assessing the medical negligence, it's looked at from a professional point of view. And I'd like to point out that, as health practitioners, we have the HPCSA that really puts up the professional standard. So any allegation is an allegation of unprofessional conduct. And the generic test for that is one of foreseeability and preventability. I'm just going to talk a little bit about that in the coming slide. But the most important thing is that any allegation of negligence is measured against a professional standard. This brings me to thinking about, there's no professional standard when it comes to driving. If you drive, you can be charged of negligence, but there's no code of conduct to really hold everybody accountable to. I remember a certain judge a few years ago here in Sandton, when this judge in the wee hours of the morning went into, invaded, the property of some other person. He was judged from a professional point of view. I hope doctors don't get into that situation. Key elements for medical negligence. I think we know that for medical negligence, all these 5 elements, conduct, wrongfulness, fault, causation, and damage should be there. If any one of them is not there, then you cannot be charged of negligence. The first and the last one, number 1 and number 5, which is the conduct and damage, really it's not something that is very easy to prove. Let me put it that way. Conduct is an action or an omission. You did something or you didn't do something. And for conduct, really a doctor-patient relationship exists or should at least have, a role to play. Wrongfulness is important because it's a violation of a legally recognized right. When we talk of a legally recognized right, it means it is prescribed by law. So that is when we talk about wrongfulness. Fault, that's exactly what we say. The conduct must have occurred intentionally or negligently. That's a reasonable doctor standard. Would a reasonable doctor would have done this in the prevailing circumstances? Foreseeability and preventability is one of the important things that are looked at before they say that, this was, the standard is met for fault. Causation, that becomes very important. The lawyers, they talk of a factual causation and a legal causation. When we talk of a factual causation, this is what we see. This is an infection in this in this operation, but is it legally, prosecutable, or is it legally, is there negligence associated with it? And damage, it's basically, if the doctor did not do what he or she has done, would the patient have suffered? So all those 5 things need to be present before you can be charged of negligence. Let's take just a quick example of how this played out in one important case that we wanted to know. Just a disclaimer, this is not my handwriting. And also this is not Ethical's handwriting. So it's a slide or it's a picture that I saw and I liked it. I don't know whether the lawyers would like it or not. But I want to take a quick run on this case of Opelt versus the head of department in Western Cape. I think all of us know this case. This claimant was a rugby player who in a collapsed scrum suffered a bilateral cervical facet joint that resulted in paralysis. He's now quadriplegic. So he went to the courts and said, we're taking action against you, you are liable. And the case basically was a very unique case in the sense that he says, if I had not been treated within 4 hours of sustaining the injury by means of a close reduction procedure, the likelihood of me recovering is higher. Maybe I would not have been paraplegic. So the whole case revolved around the emergency treatment within 4 hours, close reduction. If the people that were, or the doctors or the people that were employed by the Department of Health in the Western Cape, if they had treated me within 4 hours, I would not be quadriplegic. Here is an important part. This case went through all the courts that we have. High Court ruled in favor of Mr. Opelt, and the department appealed. We're not happy. Then it went to the Supreme Court of Appeal, and the Supreme Court of Appeal ruled in favor of the department. So Mr. Oppelt appealed. Then it went to the Constitutional Court. In the Constitutional Court, there was a split decision. And split decision, people who played boxing will know what a split decision is. There's a majority for Oppelt and minority for the department. Therefore, at the end, the Mr. Oppelt succeeded. But I want us to go back and find out what is it this court, what happened to this court? Again, the same disclaimer. I just love this one also because I found it there. It's not my handwriting, and this is not ethical, that's saying all of this, but it's just nice to have, or it's nice to say. Let's look at the rulings that happened. And remembering the 5 elements that we spoke about, those 5 elements, the first one, which is conduct, and the last one, which is dumb, is really easy. We need to prove these 3, wrongfulness. In the High Court, the patient says, or the High Court said there was wrongfulness because the patient was refused emergency treatment, which is prescribed in Section 27(3) of the Constitution. So High Court said this patient did not receive emergency treatment because he was not treated within 4 hours. So that was accepted by the High Court. Fault, they said transfer delays at the first hospital were unreasonable. Now, there was a long discussion here around the foreseeability. Every doctor says spine injury is an emergency. So everybody knew that this was an emergency. Now the question that was out there, why was this emergency not treated within 4 hours? Therefore, the transfer delays were unreasonable. So it was not a reasonable standard. Therefore, there was fault. Causation was, now that you have not transferred this patient within 4 hours and received the expected close reduction, you have actually, denied this patient a chance of recovery. So the High Court said causation was established. So Mr. Oppelt won. When the department actually went back and started appeal, the Supreme Court of Appeal focused on the expert witnesses. So it focused on the technical aspects and it went straight to causation. Supreme Court of Appeal said the 4-hour rule was not scientifically proven and was based on class 3 data, therefore it failed. Meaning, it was not expected, it was not reasonable, it was not known, it was not a reasonable standard. It was not what would be expected from a reasonable doctor. Yes, it was an emergency, but was it supposed to have been, was everybody aware that it must have been reduced by close reduction within 4 hours at Conradi? The Supreme Court of Appeal said, no, nobody, it is not based on, expected and reasonable knowledge. And the transfer delays were reasonable, especially in the absence of the 4-hour rule. So basically it said, no, remember, all 5 elements must be present. Therefore, Mr. Oppelt at Supreme Court of Appeal failed to prove negligence. Mr. Oppelt appealed, went to the Constitutional Court. Constitutional Court majority says emergency treatment was delayed because of department's referral protocol. They said no plausible reason was advanced to show why urgent and appropriate remedial treatment needed was not dispensed. The most important thing about this case or this majority ruling is that they criticized the Supreme Court of Appeal in not following the rules or the approach to dealing with expert evidence. They say expert evidence should be based on logic from a legal point, not necessarily from a scientific point. So what they're saying that What the Supreme Court of Appeal said in terms of the class 3 data, the paper was not even published, the doctors didn't know, fine, that's a scientific argument. But the legal argument here is that, was it reasonable? Does it make sense? Is it logical? Is it known? So the majority said yes. And the majority also says if a possibility of about 50% exists, then causation is established. Minority side on the other side says treatment was not refused. There were no delays. These people, Mr. Opelt was treated based on the circumstances. It took about 3 hours for the patient to reach, Crotescure, and this is what happens. This is what is reasonable in the public sector. And since doctors were not wrong to have sent the patient, yes, doctors were wrong not to have sent this patient to Conrad, but without knowing the 4-hour rule, they were not wrong. So basically, we can all see that when it comes to the legal matters, there is no straight answer. So what does this mean? I took this straight from this paper by Workman and Kruger. And it was based on I think this paper was based on the case itself. One says not all hospitals have the skills or resources to perform spinal reduction. 78% of specialists do not agree with the judgment. 19% of specialists were unaware of this ruling. 21% of specialists covering spinal injuries have no formal training at postgrad level to perform cervical close reduction. So the expectation that this should be done within 4 hours, at least within the district or tertiary hospital, may be something that's very difficult to meet. Only 2% had training in undergrad. Transport from ER to a center takes anything up to 3 hours. So we can see from the survey that was conducted, though it was a small number of people, that the judgment has got these implications that probably it's going to be very difficult to meet, or it will be very difficult to meet. What does this actually mean? The ramifications. What are the ramifications of this judgment? I know lawyers. This was a rugby match, low velocity injury or low energy spine or cervical spine injuries. Now we're going to have cases where he says, what is the definition of low energy spinal injury? If the car is driving at 20 or 10, if I, push somebody and this person falls, if it's not going to be, limited only to the rugby injuries. Any spinal injury, our good lawyers will try and get it to be saying this was a low energy spine. Is cervical reduction reasonable doctor standard? Is it something now that we want to understand and we know? I remember as an intern that we used to put, intercostal drains. I mean, it was one of those nice things that you do on a Friday or Saturday afternoon. Because patients would come crying and say, doctor, put that pipe here, pointing into their chest. Doctor, please put it here. And you'll salivate because you want to put that pipe. It's a basic training that we did when we did our accident and emergency. Is this the training that is supposed to be standard? Is it something that, people who are in the academia and who are teaching are saying, we need to teach everybody? We need to have a good understanding of the full value chain, from injury, transport, to the medical officers, to the nurses, to everybody. Because it's well and good to say doctors must do it, but doctors, they're just part of the chain. Is it something that is supposed to be done? Are we doing it? If we are not doing it, what's going to happen? Establishment of clear protocols. What happens? It's one of those very important things. Equipment that is required, calipers and those, weights, how many weigh, education of hospital staff about the time constraints, the availability of theaters. There are lots of issues here that needs to be put into consideration. So those are the ramifications. However, when I read all about this, I thought, what else? And I found this paper about is there a possibility of a judgment that says now this mechanical thrombectomy within 6 hours in patients with acute ischemic stroke, is it going to now have a judgment if a person goes to court? I saw another case around the timing for the administration of antithrombolytics. I think it's a Tolias. I think that's a case, but it's in the UK. What is the timing for putting in an antithrombolytics? So it's one of the things that are important. One other issue for me here is that in researching and trying to do this presentation, I did not get an opinion piece from a medical person or a neurosurgeon or a spine surgeon. I saw, opinions from legal firms, criticizing, but lawyers never criticize, but they put it nicely to say, look, we think judges err. The question is that judges are allowed to err, and who looks after them? Doctors err, and judges look after them. What do we see? This is one of the most difficult slides that I had to prepare because I wanted to check to myself, what is it? What is it that I need to share with you as all participants? So I thought it's going to be easier to put just practical things that happen. What do we deal with? We interact with doctors. You cannot believe that on a daily basis we receive notifications for adverse events. These are the requests for assistance. Requests for assistance would be things like, this patient is not complying to my treatment. The husband of this patient or the wife of this patient is flirting with my staff. This one is refusing to do that. Or I was doing this operation and this is what happened. Written complaints to the doctor. Written complaints would be, I came in here, you said you'll pay this amount, I will pay this amount and I don't. Or complaining that the treatment that I got, I paid a lot of money, but there's no change in my condition. We've got HPCSA complaints against the doctor. It's a massive number of complaints that come, letters of demand. With a letter of demand, that's when then they would write, normally comes from a lawyer to say, we want a certain amount of money because you were negligent in treating a particular patient on a particular day. Request for records and summons. So we get all of those. And when we receive all of these, especially for neurosurgery, it's very clear 90% of complaints are spine related. And 90% of complaints, or a lot of these complaints, will be around nerve or vascular injuries during surgery. Some would have post-op paralysis. There's something wrong that we'd always find, foot drops. So foot drop is one of the common things that we always get patients complaining about. Patients complain that I went in, I had pain. I was operated, the pain has not gone. I went in, I had weakness of my right side. I come out, my weakness is on the left. So there's so many different complaints that we get that are embedded in these requests, in these written complaints, in these HPSA complaints, and these letters of demand. Misplacement or malposition screws. Those are some of the things that we find. Where you would say that I was operating and the screw was put differently or was put at the wrong place or was put malaligned, wrong level or wrong side surgery, no informed consent. What is interesting is that we hardly find a direct request that says there was no informed consent. What I find is people would say, I didn't know that it's going to be painful. I didn't know that it's going to infection. I was not told. I was not told that I'm going to have to go back for further operation. Had I known, I would not have done that. But it never comes out and say there was no informed consent. Then what do? This becomes very interesting. We contact the doctor. Once we contact the doctor, we request full records. Not all complaints. So we read all these complaints, then we sit, and then we discuss, and then we say, fine, this one. If it's a request for records, a written complaint, or something like an HPCSA, there's no choice, we have to request these records. If it's a notification, we would look at it and we say, this one, we need to look at it thoroughly. So we request full records, request a summary and a response of whatever has happened. We request informed consent or consent that was signed before this operation. Then what happens when we receive those documents? We go through them with a fine-comb tooth and a magnifying glass. This is the time when a lot of our doctors get irritated because we ask them, we request them, we pester them. Anyone who has dealt with us will know that we would be phoning, we would be saying, please meet the deadline. For some reason, we have a lot of doctors who fail to meet some deadline, but we go through everything. We ask questions. Now, we have the notes. We've gone through them. What do we see? What do we see in these notes? This is a direct copy, cut from patient records. These are the notes that were written by a certain doctor. A doctor is not part of the people in this because it was a different specialty. You try and understand what is written here. And once we ask the doctor, what is this? The doctor would write you a nice summary, but the actual records themselves don't reflect what the doctor has said. In our team, we have Linda. Linda has got eyes that are able to decode this kind of writing. And Linda is able to see even what the doctor who wrote the notes cannot see. And Linda will tell, oh no, this is. So when we gave Linda this, she was able to decode it. So we are grateful to Linda. However, HPCSA does not have Linda. Courts do not have Linda. Plaintiff lawyers do not have Linda. We do get other records that are like this. And when we find them like this, it's like, I wish we can just go back and teach people how to write. So you can see all of this, that there's a spectrum of those. There's a spectrum of those people that can write and those that cannot write. What are the errors that we see? Mostly illegible handwriting. Notes that are not dated nor signed. So you don't know whether this thing was written yesterday or was written at the time of the patient was seen, or when was it written. Brief and short handwriting. You try and find out what is being said here. Absent report. Yes, I did take this patient for an MRI or a CT scan or whatever types of blood. And then you say, fine, where are they? They are not on the report. Incomplete records, especially during emergencies, you'd find that, absent operation notes. Said, fine, you operated on this patient. Did you write the findings? The answer in many cases is yes. But there are some cases which says no. We just, I forgot or whatever. Absent post-op notes. It happens a lot with surgeons where you would operate on this patient goes to ICU, but is looked after by the intensivist. We have several cases where the patient complicates in ICU and sends someone to the spine surgeon. Spine surgeon says, no, I was not involved. When you look for notes, it's on the day one post-op that you have. This patient gets discharged. The surgeon that operated on this patient doesn't know that this patient was discharged. So those are some of the things that we are saying. Failure to note material non-clinical matters. There are a lot of cases where the patient would say, no, doctor, I don't want to be operated now. I want to go home to Limpopo or to the Eastern Cape to consult first before I agree on the operation. You've spoken to the patient goes. Maybe it was a cancer, comes back with metastasis, comes back being a huge problem. The doctor did not write that the patient was offered to be operated earlier, but decided or requested that he or she goes somewhere else to consult. Uncommon abbreviations, it's some of the things that we struggle with. I think the most important thing here is that poor records mean poor defense. No records mean no defense. We should keep that in mind. Thinking about informed consent, because these two, the records and the informed consent, are the most important things that we look for when we engage with the doctor. It's a very difficult thing. We've spoken about, informed consent. All of us know about informed consent. I think the question becomes, how do you present informed consent differently? I present informed consent based on the 5 elements of negligence. That was wrongfulness. If you remember, I said, actually, it's not me who said it, but it says for wrongfulness, it must be a legally valid right. We start with the Constitution. South Africa is founded on human dignity, equality, human rights, and freedoms. It's a value within our country. Therefore, informed consent, it's not something that is nice to have. It's something that defines who we are. In Section 1 and 12(2) of the Constitution, everyone has a right to bodily and psychological integrity, control over their body, not to be subjected to medical or scientific experiments without their informed consent. National Health Act, every healthcare provider must. That is Section 6.1 and 6.2. So if you don't take informed consent, you're breaking the law. It's as simple as that. In some cases, we're informed, actually the lawyer says that you're informed. If you operate on a patient without informed consent, that can be taken as assault. And you can be criminally charged for doing it. It's not a nice to have, it's prescribed by law. HPCSA, Booklet 1, Paragraph 5.3, Booklet 2, Rule 27, Booklet 4, Sections 3.1, 3.2, 3.3. This is law. So we cannot be in a situation where we do not sign informed consent. Even signing an informed consent, it must be legally valid. So with all of those, you will be able then to understand why it becomes so important to have this valid legal or valid informed consent. What do we see when we request informed consent? Generic consent forms for all procedures. You do a laminectomy, you do a cervical fusion, you do a shunt, one informed consent that says the operation. It doesn't define exactly. Knowing that each operation might have different risks, might have different benefits. Failure to have the patient to sign the copy. Here, you would see that there's a name that has been written, but at the bottom or wherever, the patient has not signed. Failure to use layman's terms. This becomes a very important one. I saw one that says the patient has got spondylolisthesis. As an ordinary person myself, I find it very difficult to say, I think this spondylolisthesis operation was due to that. At that time, the patient is actually anxious. And then there's this big word that is coming. And there's no proof anyway that this has been discussed properly with the patient. Relying on informed consent by hospitals, that's another matter. Failure to obtain consent to perform further procedures in case of incidental findings. There are patients that have complained. They said, I was expecting Dr. So-and-so to operate on me. The next thing is someone else that has operated, or someone else was involved in the operation. So those are some of the most important things that we see. The list is not really exhaustive. Lost informed consent. Doctor says, yes, I operated. Yes, there was informed consent. Please, can we see it? I don't know where it is. Okay, can you look at your notes? In the notes, there's nowhere where the doctor has written that you have discussed the benefits, the risks, the consequences, the alternatives. In such cases, then it becomes very difficult. Wrongfulness just becomes, it becomes wrongful, basically, because you've broken the law. Whatever informed consent that you sign is not valid. What can we do? It's not brain surgery what needs to be done, really. It's easy. Always adhere to good clinical practice. Develop good relations with patients. Continuously improve communication with patients. Strive for joint decision-making with the patient. That is very difficult, I can understand. But you strive and try and pull the patient closer to you and have better understanding, engage this patient, communicate, take time to improve your skills. We spoke about incompetence. We spoke about learning new ways of doing things. Consult colleagues. Participate in multidisciplinary team meetings. Do not cut corners. And in cutting corners, you know, it happens, especially in this era of medical aid, that tend to prescribe what needs to be done and not to be done, how much they can pay or how much they should not pay. At the end, medical aid will not be charged for negligence. If there was something that you were supposed to do and you know that by the standard it was supposed to be done and you didn't do it. And develop an ability to refuse inappropriate procedures. A lot of patients would come and say, doctor, I want a back operation because so-and-so had a back operation and now he's pain-free. But when you assess and you look at this patient from a clinical point, from a risk point, you can see that actually operating on this patient is not the best for the patient. But from an informed consent point of view, this patient has got a right to say, I want an operation. But from your side, you've got the ability to say, sorry, I will not operate. I should be able, therefore, to refer you to somebody else to operate you if that person will operate. We have had cases like those where a patient would have been refused operation by one surgeon. The other surgeon will operate this patient, and the patient comes back, sues the surgeon who did not operate. And also, we should not over-service. It's called, I mean, lawyers, they call it defensive management, but it's over-servicing. That was a short presentation, and thank you very much.